Hello everyone, my name is Vishal Kumar, and today I will be presenting a project titled Improving Implementation of Evidence-Based Practices Through Case-Based Consultation to Supervisors. Before we get started, I would like to thank three of my mentors that I worked with during this project: Dr. Georgiana Sedler, Dr. Noah Gubner, and Dr. Sarah Walker. I'd also like to thank the Mary Gates Research Scholarship for funding my work on this project. Evidence-based practices, otherwise known as EBPs, are the integration of the best available research with clinical expertise in the context of patient characteristics, culture, and preferences. EBPs are important because they allow patients to receive treatment that is clinically proven to help one's mental and emotional health. The specific type of EBP that we are focusing on today is called cognitive behavioral therapy, also known as CBT. CBT is a psychological treatment that focuses on a patient's relationship with their thoughts, feelings, and behaviors. On the picture to the right, we see an example of a CBT triangle. Despite research supporting the efficacy of certain mental health practices, many mental health care providers and community mental health institutions are not utilizing EBPs consistently when treating patients with mental health needs. This disconnect between the evidence base and real-world practice is a problem because patients in need do not benefit from the very therapies intended to help them. Clinical supervisors are supervisors that provide clinical direction and guidance to less experienced providers. They play a critical role in the use and sustainment of CBT. Through regular ongoing oversight of clinicians, supervisors can assess and support directly how practitioners incorporate CBT principles and how effective they are at delivering cognitive and behavioral interventions. The purpose of our project is to examine the feasibility and self-reported usefulness of providing case-based consultation to clinical supervisors that are supporting the implementation of CBT models for depression, trauma, anxiety, and disruptive behavior. Our short-term goal is to improve competency of supervisors who oversee therapists providing EBPs. And our long-term goal is to increase effective use of EBPs in clinical practice. We sent out a pre-survey via email to 10 clinical supervisors. These self-reported surveys were analyzed on Qualtrics and measured supervisor demographics, clinical experience, and perceived competency as a supervisor. In addition to the pre-surveys, 6 monthly consultation calls were conducted between 2 supervisor consultants and clinical supervisors. These calls consisted of 15-minute mini didactics on case-based supervision-related topics, such as EBP supervision with EBP ambivalent providers. The following 45 minutes were spent on case-based consultation of real supervisor scenarios. Next, post-surveys were sent out after the conference calls to assess the level of satisfaction that the supervisors had with the training and to reassess their clinical competency. Finally, 10 calls were transcribed and coded for both barriers and solutions related to clinical and supervision practices. In this slide, Table 1 shows the demographics and clinical characteristics of clinical supervisors in this study. The main takeaway from this slide is that the majority of supervisors identified as white females and were fairly experienced supervisors, as the average number of years being a supervisor was 6.31 years, and the average number of clinicians currently being supervised was around 7. In this slide, we'll discuss Table 2, which shows the self-reported general competence of the supervisors. As with this slide, in the next 2 slides, supervisors reported answers on a Likert scale, with 1 being minimal and 3 being advanced. The first 2 columns show the results of the survey, both pre and post the training. And the third column shows the change that occurred between the pre and post training. The first two rows show how supervisors felt better equipped to help providers engage with not only caregivers that were reluctant to EBP treatment, but also children who were reluctant. Rows 6 through 9 specifically speak to the increased level of competence for EBP supervision. In this slide, we'll discuss the supervisor competence for CBT plus in depression-focused treatment in Table 3, and the supervisor competence for CBT plus in anxiety-focused treatment in Table 4. It's important to note that the first three rows of both tables illustrate the large improvement that supervisors had in terms of their competence for both depression and anxiety-focused treatments. In this slide, we'll discuss the supervisor competency for CBT plus in behavioral problem focused treatment in Table 5, and the supervisor competency of CBT plus in trauma and PTSD focused treatment in Table 6. As shown in the previous slides, a similar trend of an increase in supervisor competency for treatment occurs after the training is given. In this final slide regarding quantitative data, we laid out the post-training evaluation of satisfaction and effectiveness for clinical supervisors in this study. Supervisors reported answers on a Likert scale, with 1 being very dissatisfied and 5 being very satisfied. Every row had a rating above 4.5, and some rows had a nearly 5.0 rating, which shows lots of satisfaction and an overwhelming amount of effectiveness from the training, in the perspective of the supervisors. Recently, Dr. Sedler, Dr. Gubner, and I have finished transcribing and coding 10 case-based consultation calls to supervisors. This has helped us identify both clinical and supervision barriers in implementing EBPs, and has helped us gain insight into how these calls were effective in increasing supervision competency. After finishing this step, we moved on to synthesize the qualitative data by separating the quotes that we coded as clinical or supervision barriers and solutions to identify recurring themes discussed on the consultation calls. Although we have only currently synthesized information from 5 out of the 10 total calls, some examples of what we have currently found are listed below. I'd like to give everyone around 30 seconds to read some of the examples of clinical and supervision barriers and solutions that we found. In addition to examples of barriers and solutions, we have also found some emerging key themes that were discussed in the 5 consultation calls that we have synthesized so far. The first being that some supervisors discussed strategies with clinicians that were not necessarily EBP specific, but instead they were universally effective. Some examples of this were encouragement, normalization, and validation. Another theme that we saw was that barriers at all different levels were being identified by supervisors. This included systemic barriers or organizational barriers, and even at the individual clinician and supervisor level barriers. Overall, we found that the consultation calls increased the self-reported CBT competency for supervisors throughout all of the models that were examined, and that the calls were found to be overwhelmingly satisfactory to the supervisors. The results that we have currently attained suggest that supervisor consultation calls can be used as a viable strategy for improving and promoting sustained use of CBT by community health practitioners. Our next steps will be to finish synthesizing the qualitative data and move on to publish a manuscript describing this work. Thank you.